Hello, my name is Claire Boothroyd, and I'm really delighted to introduce Dr. Padma Rekma-Jurge to us today in this podcast, which is about tuberculosis in the female genital tract. Padma has recently completed a modified Delphi consensus on the management and the diagnosis of genital tuberculosis. So we've got an expert here. And so welcome, Padma.
Thank you, Claire, and thanks to Aspire for creating this platform for exchange of information and knowledge. Thank you. So
tell us, Padma, we know that tuberculosis is a big problem in India and other parts of the Asia Pacific. Is it a big contributor to female infertility in India?
Well, thank you, Claire, for setting the ground for understanding how important this issue is. So we know consistently, despite all the efforts globally, the burden of tuberculosis remains high in many parts of the world. And to just set the foundation for this discussion, 7 out of the top 10 high burden countries are in Asia Pacific region. India has the highest burden with 27% of people affected with TB living in India. So, and to name a few other countries are China and Indonesia. So we have a very high burden in this Asia Pacific region. Interestingly, genital tuberculosis is one of the commonest forms of extrapulmonary tuberculosis. And as you know, extrapulmonary tuberculosis is very common in young population, sort of between 15 and 45 years of age. And women seem to be more often affected with extrapulmonary tuberculosis than men. So it is a very important problem.
So what are the challenges of identifying the condition?
Yeah, I think that leads to another very important area in this when we are dealing with genital tuberculosis in women. I think traditionally, when we were in medical school, we were taught that fallopian tubes are the most commonly affected organs, and 90% of affection happens in fallopian tubes, followed by uterus and ovaries very rarely. But with the the modern tests and investigations, we know that all these organs are very often affected simultaneously. And with the use of hysteroscopy, we identify finer nuances of uterine damage. And with the use of transvaginal ultrasound, we identify, very often subtle changes in the endometrium, the endometrial thickness. Similarly, previously, we used to think only of tubo-ovarian masses as an indicator of ovarian damage. But now we know with the robust ovarian reserve markers, such as AMH and antral follicle count, we know that the ovarian reserve is affected. So, we need to adapt these increasing understanding of female genital tract through the modern methods to identify this condition. But the most important challenge is it's a paucibacillary condition, like any other extrapulmonary tuberculosis. So, and the problem for us is usually the tissue used for diagnosis is endometrial biopsy. And we know that endometrium is cyclically shed. So we don't get the typical granulomas or typical inflammatory lesions. So that is one challenge. And very often it happens in otherwise fit and healthy women. They're just having infertility and they have no signs and symptoms of tuberculosis as such. So it's a subclinical infection. There is no structural damage through when we investigate them through conventional methods such as laparoscopy or hysteroscopy. But yet we know that subclinical TB is also causing local inflammatory damage. So the paucibacillary condition is the thing which is the main limiting factor for us to identify it as often as we would like to.
Okay, so just recapping, it's a common problem in women in India, and they don't necessarily need to have pulmonary tuberculosis. It can be just purely genital, and it's a porcine bacteria or porcine bacillary in nature. I remember when I was a medical student, they used to say which organism, if you only find one of them, is always a pathogen, and it was Mycobacteria tuberculosis or tuberculari. Okay, so it's often subclinical, and so we've got to think of it in things like thin endometrium, and if there's evidence of hydrosalpinges or blocked tubes, but it's often subclinical. Okay, so how do we investigate it? How do we diagnose it and investigate it, Padma?
Yeah, I think various researchers have looked at various modalities, and we have broadly two sets of tests available. One are the conventional ones where we do a smear of the tissue and histopathology, but we know that because of its bacillary nature, subjecting endometrium for a smear test is futile. And histopathology very rarely is informative because the endometrium is periodically shed. The classical granulomas do not develop. Bacterial culture is still considered as the most diagnostic gold standard for diagnosing microbacterial diagnosis. And we have moved from the conventional LJ medium to liquid culture media now, which has cut down the duration of wait we have to identify this. The advantage of culture positivity is that apart from identifying the bacterium, it also gives us the drug sensitivity. So it's an extremely helpful investigation. But culture needs a certain amount of bacteria to be present in the tissue to grow it. So again, it's better for fluids than tissue. So for endometrium, this again is a limiting factor. So, and the other thing is when it is in subclinical form, sometimes it develops, the mycobacterium develops certain features in its wall where the culture cannot identify it. So these are the issues. So more and more we look into the molecular diagnostic methodologies, and WHO has actually stated that one of the platforms, point of care platforms, GeneXpert and GeneXpert Ultra, can be effectively used for diagnosing tuberculosis. So these DNA PCRs are probably the mainstay for diagnosing female genital tuberculosis.
Okay, so culture is harder to do, and do we do it on an endometrial sample or endometrial washings, or is that what we do if we're going to do culture? Is that right?
It is on endometrial tissue. It is on endometrial tissue.
Okay.
Of course, if there is pelvic collection, large collection, if there is a walled off pus, then probably it's more likely to yield mycobacterium than endometrial tissue.
Okay, but the molecular tests are better, and are they expensive, or is there a fast turnaround on those ones, the molecular tests?
Yeah, I mean, of course, DNA PCR tests are there's fast turnaround within 3 to 4 days. We do get the reports. GeneXpert also. Because most of the countries are now committed to the WHO's initiative of eradicating tuberculosis. GeneXpert in India is available on all government platforms. So whether we are in public sector or private sector, we can utilize that platform. But one of the caveats with GeneXpert is it utilizes a particular gene probe to identify Mycobacterium tuberculosis. And most of the countries have more than one lineage of this Mycobacterium. So in India, it is estimated that up to 1/3 of the bacteria present belong to a lineage which is not going to be identified by GeneXpert. So we may have to rely on what we call as homebrew kits, like tailor-made DNA PCR kits to diagnose depending on the geographic area, but they all have a fast turnaround. Cost-wise, yes, they cost a couple of thousands of rupees in Indian currency. But with increasing use, I think the cost of these tests can be brought down.
I must admit, if you're going to miss 30% of it, so what are the alternatives to GeneXpert? Are there other options that we have? I mean, are skin tests useful? There's also another test that can be done, isn't there? I'm just trying to remember it.
Tuberculin test and
Yeah.
Manto. Yeah.
They
So
have
I
a
think,
place?
I mean, with both CDC and WHO have stated that these tests should not be used in high dense, high burden countries, because most of the people will have a positive tuberculin or Manto test. So probably the answer is using multiplex DNA PCR based on, as I said, depending on the more common, the most common lineage of the bacteria existing in any geographical area. So it does show how complex the situation is. We may have to know where the person originates from, because we have no idea when they would have got that infection. It might be staying there quietly for a very long period of time. So, yeah, I just wanted to add that one of the problems, one of the advantage of gene expert coming positive is it does identify if there is rifampicin resistance, which is very important for us. But the various DNA PCR platforms available will only diagnose the condition, but doesn't give us bacterial sensitivity, antibiotic sensitivity.
So if you diagnose it by molecular routes, do you have to chase the culture in order to get the sensitivity to start treatment, or do you use empiric treatment, or what happens then?
The problem is, we do culture and the molecular tests simultaneously, but most often the culture comes negative. So we have to rely on the molecular test. In future, there might be scope for using NGS to actually identify, antibacterial sensitivity. But at present, we go by the national guidelines where the usual treatment for genital tuberculosis is what we call as the standard anti-tuberculosis treatment, consisting of 4 drugs for the first 2 months and then 3 drugs for the following 4 months.
And what's the prognosis for genital tuberculosis? Is it good with treatment?
I think this is the most important and most exciting area for people in reproductive, working in reproductive medicine area, I think. So if we identify, Claire, you know the consequences of irreversible uterine damage. If somebody has tubal damage, we treat them with anti-tuberculosis drugs if they have TB, and then they can have successful pregnancies with IVF. But it's not the case with uterus. If there is an irreversible damage, they need to go through surrogacy. And we know the legal and financial issues associated with this. So not everybody can afford or can go through surrogacy, or might be, they may not even be willing to do that. So if we identify this condition before a permanent irreversible uterine damage happens, so we improve their chances of having successful implantation and successful live births. Similarly, if the ovarian reserve is reduced but not totally damaged, again, treating the condition will help them to have their own biological child. Again, the issue of third party looms large for those with having very low ovarian reserve. So these are the very heartening things, and the work is going on as far as it's an ongoing task to look at what happens to the ovarian dynamics after treating, and there is some published data and probably more on the way to show that there is a longitudinal improvement in the ovarian reserve. So after treating for tuberculosis, so that is something, we all believe that once the ovarian reserve is damaged, it's a downhill process. We don't think that it can be improved. So with this condition, maybe there is scope for rescuing the ovarian reserve. Not in all, but in a large majority of them.
So really, what I'm hearing is that in your practice in India, if you're doing a hysteroscopy for a thin endometrium or for unexplained infertility, or that there's abnormal reduced ovarian reserve or a suggestion of tubal disease, you should always look for tuberculosis in the Indian population. Is that right?
Yes, yes. I mean, our national guidelines also say that infertility could be the only sign and symptom of tuberculosis. Yes.
And obviously for people like me in Australia, where we have a multicultural society, we have a lot of people who come from the Indian subcontinent who live with us. So we could easily miss that in Australia, because it's just not on our radar. So this has been very enlightening for me. I think it's something that we need to be very careful that we don't miss, because you do allude to the fact that it is, for the most part, treatable. It's a long course of treatment, 6 months, isn't it, at least? But it does actually, there seems to be evidence that it is at least in part reversible, possibly with the reduced ovarian reserve, and as long as the adhesions aren't too bad. I mean, you could always presumably divide the adhesions and start to work on that. It's been a very, very interesting session. Thank you very much, Padma, and for bringing Mycobacterium tuberculare under the microscope for us in fertility. So thank you very much. This is an Aspire podcast, and I hope you enjoyed it very much. We look forward to your feedback. Thank you.
Thank you, Claire. Thank you.